etterpå, eller?
Ned og så, ja.
Screen, now it's live. Okay.
It works. Good afternoon, and welcome to this launch of our new research center called Oslo Research Center of Physical Activity and Population Health, with this wonderful acronym ORCPAP. My name is Sigmund Andersen. I am currently one of the leaders of ungPAP, and we have 4 objectives. The first one is to continue and further develop the national studies of physical activity and physical fitness. Second is to study sedentary time and physical activity with various health outcomes throughout the lifespan, with special emphasis on dose-response relationship. The third one is to conduct intervention studies to evaluate how exercise can impact specific health outcomes. For instance, in the primary care, we call this third objective for exercise is medicine. And the fourth one is to transfer research results to public health and policy initiatives. And we have a vision. The vision is to develop, together with colleagues, the center to a focal point for a national research network, as well as to further develop our international research collaboration. To open ungPAP, we are honored to have Rector Åge Radmann here, and also the director of the Norwegian Institute of Public Health, Guri Rørtveit. The first speaker will be Åge Radmann, and then Guri Rørtveit. Please, Åge.
Dear colleagues, partners and friends of Norwegian School of Sports Sciences, it's a great pleasure and an honor for me as director to welcome you to the opening of the Oslo Research Center for Physical Activity and Population Health, or ungPAP, as Sigmund said. Today's occasion marks an important milestone for the Norwegian School of Sports Sciences. With the establishment of this center, we send a clear and ambitious signal. Physical activity and population health are, and will continue to be, high priorities for our institution. At a time marked by complex health challenges, both nationally and globally, it's essential that knowledge institutions take a clear societal responsibility. Over several decades, the Norwegian School of Sports Sciences has developed a strong and internationally recognized tradition of robust measurement, methodological development, and interdisciplinary research. The new research center builds firmly on that foundation. ungPAP will bring together leading academic environments in Norway and internationally, with a clear aim to strengthen the knowledge base for policy, practice, and decision-making in physical activity, physical fitness, and population health across the life course. Physical activity is one of the most powerful, yet still underutilized tools in public health. Our particular strength lies in the integration of research, education, and practice. This center is therefore a clear expression of the societal mission of the Norwegian School of Sports Sciences to develop knowledge that is not only published, but also applied. I would also like to take this opportunity to express my sincere appreciation to the research leader, Professor Sigmund Andersen, and Professor Ulf Ekelund, the head of department, Hege Klem, as well to all the outstanding colleagues at the Norwegian School of Sports Sciences who have contributed over time to make this center a reality. Their academic leadership, integrity, and perseverance have been essential. ungPAP is the result of collective effort, professional generosity, and a strong culture of collaboration. Thanks to all of you. The challenges related to physical activity and population health transcend national borders. We are therefore particularly proud of the strong partnerships connected to this center, including the Norwegian Institute of Public Health and the World Health Organization, the latter with whom we are also a collaborating center. We are very proud of that. These partnerships give us not only a special responsibility, but also a unique opportunity to contribute internationally with high-quality research and knowledge. No single institution can address these challenges alone. Real impact requires collaboration between academia, public authorities, and the field of practice. ORCPAP will serve as a meeting place and a catalyst for such collaboration. The Norwegian School of Society, or the Norwegian School of Sports Sciences, aims to be an open, active, and relevant partner, both nationally and internationally. And finally, as I mentioned, we depend on strong partners to succeed, and no one knows this field better than the Norwegian Institute of Public Health. So it's a great pleasure to introduce the director of the Norwegian Institute of Public Health, Guri Rørtvedt. The floor is yours. Thank you.
Thank you so much. Can you hear me at the back? Yeah? Dear guests, partners, and colleagues, it is a great pleasure to be here today and at the Norwegian School of Sports Sciences to mark the opening of the Oslo Research Center for Physical Activity and Public Health. This center represents something more than just a new organizational structure. It reflects a stronger shared commitment to knowledge, collaboration, and action in one of the most fundamental areas of public health, physical activity. Physical activity is not a marginal factor. It is one of the most powerful drivers of health. It reduces the risk of non-communicable diseases, improves mental health, and contributes to quality of life across the lifespan. Yet the paradox is clear. We know a great deal about its benefits, but we are not succeeding in making populations more active. It is not enough to document effects or increases in physical activity. We must also understand how to create change at scale, how to reach different groups, and especially how to reach those who are least active, where the potential health gains are greatest. This challenge is both national and global. Physical inactivity is one of the key indicators for non-communicable diseases and is included in the United Nations Sustainable Development Goals. There is a global target to reduce physical inactivity by 15% by 2030 compared to 2015. In Norway, we have a solid collaboration between the Norwegian School of Sports Sciences, the Directorate of Health, and the Norwegian Institute of Public Health when it comes to monitoring and reporting on the development in our country. Through studies such as ungKan and ungKan, we have unique, high-quality data from device-based measurements of physical activity. These data are a major strength. They provide precise estimates and insights into temporal trends that are difficult to assess using self-reported data. But they also tell us something we cannot ignore. For some groups, particularly children and adolescents, trends are moving in the wrong direction. Furthermore, across the population, we see clear social inequalities in activity levels. If we are to change this, we need more knowledge and we need better knowledge. We need improved methods and even more precise data. We need better understanding of differences between population groups, and we need stronger evidence on which measures and interventions actually work. This is where ORCPAP becomes so important. The new center is a significant strengthening of the collaboration between the Norwegian Institute of Public Health and the Norwegian School of Sports Sciences, and between Norwegian and international research community on this field. As a WHO collaborating center, ORCPAP also connects us more closely to global efforts in this field. The strength of this center lies in its complementarity. Together, the Norwegian School of Sports Sciences and the Norwegian Institute of Public Health create a stronger foundation for generating knowledge that is both scientifically robust and practically relevant. Ultimately, this is not about studying physical activity. it is about enabling change. Change in how we design interventions, change in how we prioritize resources, and change in how we reach those who benefit the most. Norway is well positioned to contribute. We have strong research environments across several universities in the country, high quality data, and a long tradition of collaboration. With ungPOP, we now have a unique opportunity and platform to bring these environments even closer together, to strengthen collaboration nationally and increase our impact internationally. This will strengthen knowledge development and our ability to translate knowledge into action. And ultimately, it will help us contribute to a more active population and better public health in Norway and beyond. A more active population is also a more resilient population, better equipped to cope with challenges, including in times of crisis. Thank you.
Tusen takk. Thank you very much. I have the pleasure to be the chair for the first part of this session. And next presenter is Dr. Joanna Wilhelmsen. She's a technical officer of the World Health Organization in the Department for Health Promotion. She has, among others, coordinated the development of the first WHO guidelines on physical activity, sedentary behavior, and sleep for children under 5 years of age. She has done a lot more, but I guess I will stop there. And it's a pleasure to have you here, and the podium is yours. Please give her a hand.
Thank you very much, and thank you for inviting me to be part of today's event. So I think we heard mentioned, and Guri, you brought up the fact that this centre is now also a WHO collaborating centre. And that's a great addition, I think, to the strength of the centre that we have here. So I've just been asked to give a little introduction as to what a WHO collaborating centre is. Now, WHO's history goes back, way back to the League of Nations days, days when they started to recognize the important contribution that research centers can make to global health, and designated a number of centers to be centers for standardizing biological products, or the first WHO center was one about surveillance on influenza. But today we have over 800 institutions that are part of this global club, collaborating centers that support WHO in delivering our core mandate. And they're spread nicely across the world. Over 80 countries are represented, obviously with more in certain regions, but these are growing, and that spread is getting greater and greater every time. And they fulfill a number of diverse functions, supporting WHO in collecting and disseminating information, standardizing terminology, for example, and developing appropriate technologies that can be used across health at a global level. They're reference standards, they provide other services, they support us and help us in training and delivering training to help countries implement the policies of WHO, as well as coordination of these various activities. But not just any centre can become a WHO collaborating centre. Those 800 represent centres that have had a history of joint collaborative work with WHO and have been invited to become collaborating centres over time. They represent a significant institutional capacity to deliver on that core mandate. And very importantly for WHO, we've assessed whether there is any potential conflict of interest. As the global organization, the specialist UN Organization for Health, we have to maintain that integrity, and that's a really important part of the work that we do in assessing potential collaborating centres. So the other day I just did a quick search, and currently we have 41 collaborating centres that, if you search on physical activity, pop up. These are some core ones that have really core work on physical activity as an NCD risk factors. Centres in Sydney, in Wollongong, also in Australia, in Japan, a couple of centres in Germany and one in Zurich, in Switzerland, and now this one here in Norway that joins that club. But if you look across those centres, there's also some that focus on different areas, different topics, but that all can contribute to physical activity, reducing physical inactivity, and addressing that as a core NCD risk factors. Things like healthy aging, active transport, systems thinking, social marketing. And I think what's become really interesting is the way that many of these collaborating centres actually now interact, particularly across these diverse topics that can have contributions to helping populations become more active. And so there are many more. There's a public site where you can access all of this information. The link is there, and we're happy to share it. But today we're really here to celebrate the work of this centre. So with that, I'm going to pass over to Ulf, just to talk to us a little bit more about some of the specific areas of work that will be covered here in Oslo. Thanks.
Thanks, Joanna. So, as you've heard this morning and early on during this session, our newly established research center is about physical activity and population health. We are interested in monitoring physical activity levels in the population. We're interested in how physical activity relates to non-communicable diseases across the life course, and how the dose-response associations between physical activity, sedentary time, and health outcomes looks like in these populations. More specifically, what we have discussed over the last, I think, 2 years with the physical activity group at WHO is how we can contribute to their work. And it aligns perfectly well with what we are doing in our collaborating, or in our newly established center. We are supposed to provide support to inform future guidelines. WHO published their first guidelines on physical activity in 2010. They were updated in 2020 with including sedentary behaviors. And there is a plan to update these guidelines in 2030. The work we are doing here in Oslo hopefully can support those guidelines. We are doing some important stuff already. We have started working on systematic reviews on physical activity and sedentary time for prevention of obesity. It's a specific task, how physical activity may prevent development of obesity. We are doing meta-analysis and systematic reviews on device-based physical activity and sedentary time with cardiometabolic outcomes in children, which may also inform these guidelines. Anders is here somewhere, he's leading that work. Jakob is leading the work on the systematic reviews. These are ongoing work that hopefully will inform future physical activity guidelines. We're also working on wearables. We're working on measuring physical activity. We're working on how we can really compare different methods, different device-based methods on physical activity, and very, very closely in collaboration with the National Institute of Public Health, with Knut Erik, Ole, Johan, Anders again in the audience. We are currently working on in a bigger European-funded project. We are working on device-measured physical activity in a random sample of the population in Oslo, with one device placed at two different placements on the body, which may inform future work with WHO. WHO are planning to implement device-based measured physical activity in future surveillance systems, leaving the self-reported data, going on to device-based measures. Our work on comparing different placements with accelerometers may inform that. So we are doing work, and we will continue to work with WHO to expand the knowledge base, specifically for the points you can see on the slide. Thank you.
Okay. Now we will do a stunt. So Ralman, Rørtveit, Tjena, Ulf, because now we will.
Have you done a risk assessment with it? I'll do it later.
Now we will officially declare. Come on.
You tell us when.
OrgPAP for opened. 1, 2, 3. Okay. Yeah. Okay. Gikk ikke det bra? And now, it's a pleasure to introduce Inger Ariansen. She will present NCDs in Norway, status and trends. She is a medical doctor, a senior researcher at the Norwegian Institute of Public Health. She leads the national collaboration on NCDs. She has extensive experience from epidemiological studies linking nationwide population-based health examination studies with national health registries. So, Inger, find your place. And give her a hand.
So, thank you very much for the invitation to present the current status and trends in non-communicable diseases in Norway. And I will focus on premature mortality. So, Norway has committed to the UN development goals and especially the goal on health is a continuation of the WHO global targets for non-communicable diseases. And here the main target is to reduce premature mortality before the age of 70 years from non-communicable diseases by 33% from 2015 to 2030. And non-communicable diseases are shortened NCDs, but I guess you already know how to say it. So, and here the NCDs include cancer, cardiovascular diseases, diabetes, and chronic pulmonary diseases, mainly COPD. The WHO have made 9 targets that include these main targets and 8 other targets regarding factors that are affecting the development of the NCDs. And these targets are directed towards the health services, but also towards the health behavior, such as alcohol consumption, physical inactivity, as we've heard, salt, tobacco, and other. So here is the development over time for premature NCD mortality in Norway. On the x-axis, you see the calendar years from 2005, and on the y-axis, it's mortality as number of deaths per 100,000 inhabitants and the Numbers are age standardized, which means that we are fixing the age distribution so that we can compare the numbers over time and not having to take into account the aging of the population. So the numbers are comparable over time. And if we look at the period where we are looking into the target achievement from 2015, we see that there's been all in all a 21% decline in premature mortality. But we also see that there is a somewhat less steep decline during the period from 2019. So the question is, will we be able to reach the target? If we base our assessment on the development since 2019, it appears that achieving the target by 2030 will be challenging. But still, we will be quite close based on these analyses. And if we look at the sexes, we see that men have higher premature NCD mortality than women. And that's especially driven by a higher cardiovascular mortality in men. And actually, as you see, the mortality from cancer is quite similar for the sexes. And here we also see that this trend that we have like the flattening from 2019, that is actually seen in both sexes. So in addition to looking at the total NCD mortality, we also follow the trends for factors that influence this development. So we will look into a few of those factors now. And here we have the proportion with high blood pressure in Nord-Trøndelag in men and women. On the x-axis, you see the different Hunt studies from Hunt 1 in the mid-80s up to Hunt 4 in 2017 to 2019. As you see, there's a favorable decline in the proportion with high blood pressure. And we have shown it for 10-year age groups. So you see that the decline is actually going down also in the lowest age groups. And also another point to look into is that you see that the spread from between men and women are quite different. So in fact, the women, the female cardiovascular system has to kind of adapt from a quite low blood pressure into a quite high blood pressure. And the oldest women actually have higher blood pressures than the oldest men. Yeah, I had to talk about gender differences as well here, sex, yeah. So, and then the thing is that we now have Tromsø 8 study is now being conducted, and we have some preliminary results from Tromsø because we're very excited about whether or not this blood pressure will continue to decline or not. And here are the results. As you see, for both the age group 40 to 49 and 60 to 69, it seems like the level of systolic blood pressure is still declining. So another of the risk factors that we are looking especially into is the trends in obesity. And here we see the proportion with overweight in yellow and obesity in red in Nord-Trøndelag. And we've kind of chosen to also to put these categories on top of each other so that we can see like the total height of the bar is the proportion with both overweight and obesity, obviously. So, but if we look at the red parts, that is the proportion with obesity, we see that there was a kind of sharp increase from Hunt 1 to Hunt 3, and then from Hunt 3 to Hunt 4, it has been a less steep increase in obesity. And we also have some preliminary results from the Tromsø 8 study on obesity. And here we see, in fact, that for the 40 to 49 year group, it seems to be a decline, but and for the 60 to 69-year-olds, it seems to flatten out for men and even decline for women. But we have to remember that these are preliminary results from November 2025. Actually, there will be some new results, but they will be at the end of this week, so we weren't able to have those from Tromsø. But it will be, we have to kind of remember that these are preliminary and we can't kind of conclude. So then I think I'll just show you all the goals, the targets, and how Norway are on track or not regarding those 9 targets that I mentioned at the beginning of my talk. So here we have all the 9 targets, and as you see, there are 4 of the 9 targets are marked in green, meaning that they are going in the right direction. That is for the target number 1, premature NCD mortality, and it's also for blood pressure, as I showed you. We have had kind of it's going in the right direction. And there are 2 other targets at the bottom that says something about the healthcare system's ability to tackle NCDs. It is target number 8, that at least half of those who need it receives drug therapy to prevent heart attacks or strokes. And it also actually includes whether or not they receive counseling, but we don't have data on that. But we have data on drug therapy. And the last target is whether or not their NCDs medication that are essential are available to the public, and they are. So the goals, and also I mean like the blood pressure goal will also be related to treatment with blood pressure lowering medication. So part of those goals that or targets that are linked to the healthcare system is actually marked with green. But when we look at the health behavior related targets, the development is not that good. For alcohol, the target was to have at least 20% reduction in harmful use from 2010 to 2030. And here we actually have had more or less a flat development over time. There has been some uncertainty because we used to look at the total alcohol consumption, and after the pandemic, before and after the pandemic, these numbers changed. So we've kind of had to look at several data sources at the time, but still there is no clear sign of change. And then we have like tobacco use. We had a very favorable decrease in daily smoking, which has been kind of the most important indicator for tobacco use, and also the most important for development of NCDs. But still we see an increase in non-daily smoking among young men, and also increase in snus use among adults. And then we have 3 targets that is not going in the right direction. That is the target that Guri mentioned on physical inactivity, where we kind of wishes for a reduction in inactivity by 15%. And as we have seen for children and adolescents, we are not approaching the target. But we see a small decline in adults. And then a salt reduction. We are not approaching the target of a 30% reduction in salt intake in the diet. It is actually measured in Tromsø, the Tromsø study and the Hunt study. And it has been higher than what is the limit that is favorable, and it has been stable over time. So here we are not even approaching the target. And also the last target, 7, to halt the rise in the proportion with diabetes and obesity. We see that more and more people are living with diabetes. That is also because we are treating them so good that they survive, which actually should be good. So it's a bit of a strange target in one way. And for obesity, we kind of see a sign of less steep increase in obesity, but we can't now say that we have halted the rise in obesity. We have to wait for the Tromsø 8 numbers. All these, the ability to produce this table is based on high-quality data that is collected in the ungKan study, in the Tromsø study, in the Hunt study, and other studies. So there is a tremendous effort that lies behind these numbers. So being able to produce these NCD indicators and to say something about the targets is a national effort in the national NCD collaboration that consists of several universities, as you see, including the School of Sports Sciences. And also we have included quite a lot of partners that are using the data. Municipalities, counties, Nasjonalforeningen, and the Norwegian Directorate of Health. And this national collaboration has together defined the NCD indicators and also are updating them annually. In addition, this collaboration applied for research funding and got funding for the NCD North project, which kind of is has the aim to elucidate the development of the NCDs and to identify the causes behind the causes for this development. So to summarize, premature NCD mortality has declined by 21% in Norway from 2015 to 2024. The decline has been less steep since 2019, and it may be challenging to reach the target of a 33% reduction by 2030, even though we are a country with lots of resources. So for the targets, we see that, especially for the health behavior targets, we are not approaching the targets regarding alcohol consumption, occasional smoking, salt intake, and physical inactivity in children and adolescents. But there is signs of less steep rise in obesity. So the conclusion is that we need to continue to develop high quality knowledge to say something about future trends. Thank you.
Tusen takk. Thank you. Joanna, I think you are on again, and I just introduced you, so I won't do that now. Please.
Thank you. And thank you, Inga, for really taking us through those NCD risk factors and the targets that have been set with WHO. And I think, following on from your last point, the value of high-quality knowledge and data, I'm going to link with that because I'm now going to go on to talk about guidelines, and specifically guidelines about physical activity. And this really is part of WHO's core mandate and responsibilities. But the first one of our responsibilities is really to articulate evidence-based policy options. That's what countries are asking us for. That's our core contribution. And for physical activity, we have the Global Action Plan on Physical Activity that was launched in 2018. It has a resolution at the World Health Assembly. So all countries of the world that are members of WHO have signed up to this action plan and to that target that we mentioned, that 15% relative reduction in physical inactivity. It's always a bit confusing. We're talking about people not being active enough, and we want to get them more active. Our second really important core function is setting global norms and standards. And these two things are linked because I'm not expecting anyone to see all the detail in this slide. This is a slide of the 20 policy recommendations in the Global Action Plan. The blue ones are all about what governments need to do, the policies that underpin things that we can do to help people be more active. And the very important one there is guidelines, because guidelines, I always see them as a cornerstone for policy development. They tell us how much physical activity people need to be doing for their health and help us guide our policies moving forward. But it's not about individual physical activity in itself. Because I'm talking about the evolution, I tried to find a nice old photo, and I thought this one was quite good. But really, we are talking about population-based. These are public health guidelines. So for the person on the street, not necessarily for that bodybuilder that we saw there with his dumbbell. But they're also public health guidelines that need to be globally relevant. So it's great to be talking about what's happening in Norway today, but I'm also really interested in what happens in Namibia, in Peru, in the Philippines, because as WHO, we need to provide that support to all the countries of the world. And as Ulf mentioned earlier, our first guidelines were produced in 2010. And thanks to the introduction that I was involved in these very first guidelines that we had for a particular population, for children under 5. These were actually called for by the Commission on Ending Childhood Obesity, that recognized that WHO didn't have guidelines for this age group, that this was a really important phase of life when children are starting to establish some of their healthy behaviors, and that we really needed to provide parents and caregivers and educators with advice about physical activity, sedentary behavior, and very importantly, sleep. It's a particular area of concern for this age group. But then in 2020, we updated our recommendations from 2010. We added sedentary behavior because there was now more evidence to support recommendations on sedentary behavior. And we also expanded the populations that we addressed. So these guidelines in 2020 cover children from age 6 upwards, adults, older adults, they were covered in the originals. But then we also expanded to pregnant and postpartum women, to people living with NCDs, so living with chronic conditions. And sadly, it was a limited number of chronic conditions that we could actually review the evidence for, but that's a really important group. And then for children and adults living with disability, and this is an area where the knowledge is really lacking. We were struggling to find good studies about physical activity when it's not clinical and it's not about rehab, but about general physical activity for these populations. And so we made a really important call for more research. And this again is one of WHO's roles, setting the research agenda, identifying where the gaps are, and working with people such as yourself to help us fill them as we go forward. And so with that, we've actually managed to span the whole life course. And that's a really important aspect for us, taking it from the very youngest to the very oldest, including people living with chronic conditions, including people living with disability. And how did WHO do this? We have a really rigorous methodology for developing guidelines. I sometimes say that WHO doesn't move very fast. We maybe move slowly, but we move in such a way that countries have great confidence in what we do, because we review the evidence very carefully. We expand reviews to make sure that they are global. We do searches in other languages to find studies that have been published in languages beyond English. We have a guideline development group. You see photos here, you may recognize a particular face in some of these, who help us, who review that evidence, who help us develop recommendations. They're a group that's picked for their expertise. They're also globally representative. They represent not just academics, but also some of the end users of our guidelines, so that we're really getting a broad opinion on these to help us develop those recommendations. And ultimately, we come up with our recommendations. It's a lot of work, and it gets summarized in this very simple graph, but I think it captures it all. We have those recommendations. This is a summary for adults to achieve between 150 and 300 minutes of MVPA a week. This is just one aspect of the guidelines, but it's probably the most commonly used graph that we have, because it really does summarize it. But there are other recommendations within that, and there are other, what we call good practice statements, because we recognize that that recommendation may not be something that everybody feels that they can achieve. But it's really that importance of limiting extended sedentary time, of doing some. Some is better than none. More, obviously, is better. But I always draw attention to the steep part of that graph, where the guy in the armchair watching TV actually gets up and starts doing something. That's sometimes where we get the greatest benefits that we can see at the beginning. This is just an infographic to summarize it. And this video, I think, takes us from our friend with the dumbbell in the gym to how we message physical activity recommendations today, because it is all about every move counting, getting that shift in populations away from seeing it just as sport or exercise or something you have to go to a gym to do, but rather as this. These are the documents. I think one of the great things that's come out of those 2020 guidelines is that they have been really widely adopted by other countries. So we produce the global guidelines, but many countries have national guidelines of their own. And we've seen that this document has now been translated and used as a basis for national guidelines in over 40 countries. So that's 40 countries that haven't gone through that rigorous process of reviewing the same evidence, because it's the global evidence that's out there, but instead have adopted the WHO documents and used the resources, both human and financial, to do much more work on implementation of these, actually some of those activities and initiatives we need to change people's behavior. These guidelines sit within the policy documents we have, the Global Action Plan, a Global Status Report, which was a stock take of how countries are doing in terms of implementing the policy recommendations. And then in 2024, we published new estimates of levels of physical inactivity in adults. And the data, as you well know, hasn't been terribly encouraging, and we're really not on track to meet those targets that we have set. But what next? What next? As Ulf mentioned, it's not too surprisingly, 2010, 2020, 2030 will be the next guidelines. We're already starting work towards those. Because what's new? And there is a lot that's new this time. We've got much more evidence based on wearable devices that adds a complexity to the evidence reviews that we'll be doing, but adds a really important new aspect to that. Because we're seeing data that indicates that maybe there's something we can do, particularly for people who are not particularly active. We can add a little bit more, and that might have an important health impact. So as we plan towards 2030, we are cooperating with multiple countries. As I said, those guidelines have been adopted by many countries, so now we're actually proactively looking to work with countries as we develop the new global guidelines so that they will be adopted more broadly. And so we can actually be more efficient in the way we use all of our resources, pooling our effort to come up with global guidelines. We've already commissioned a number of reports, technical reports on different aspects. We're scoping the extent of the evidence out there. And recognizing the complexity of that new wearable evidence, thinking about a framework of how we will assess the different behaviors, the metrics, and the new health outcomes. Also looking towards new health outcomes that maybe we didn't look at in the 2020 guidelines. Shortly, we'll be convening a guideline development group and probably several subgroups, because as you saw, if you've got a life course approach, plus different chronic conditions and different special population groups, we need expertise that will cover each of those. And then finally, review that evidence, develop the recommendations, draft the documents, and make these guidelines real. But it's complex. It really is, and it has so many different aspects to it. There's the research and that knowledge that gets generated that contributes to the guidelines. And then ultimately, the guidelines and the recommendations we set are what we then monitor when we look at population levels of physical activity. And it's that monitoring that lets us see if we're getting there to that target. So back to the population in general. This is a great population, because look at them, they're walking. They're actually walking in Barcelona, I think. But the truth is that there's much more of this happening than that walking. And as I mentioned, the trends are not positive. The new data we published in 2024 showed that we've had an increase in levels of inactivity globally. There's some variation in certain countries, but overall, it's getting worse. And so we've got more people not benefiting from those health benefits of physical activity. And for children and adolescents, it's really worrying, because that's up to 81%. And just so you know, we're currently working on an update of the adolescent data, and that should be published later this year, I think. So that update is underway. But ultimately, we're off track. We're not going to make those targets for 2030 unless something changes radically. So how can guidelines contribute to that? Because guidelines in themselves don't change behavior. It's what we do with them that actually makes the difference. And maybe with the 2030, if we have new recommendations, new ways of explaining to people the physical activity they need to do and how we can message that better, maybe that will help us to change behavior. What can we do to get the least active to start doing something and getting those health benefits? And very importantly, how can we move from seeing physical activity as something just of individual behavior that people have to change to making it something about policy change to support people to be more active? And ultimately, to bridge an implementation gap that we've seen where policies sometimes are in place, but they're not necessarily being implemented and really helping populations to move more. And as WHO, we produce tools to help countries implement these policies. We have training programs that are available online as well to do that. And we have a really important role in supporting countries to monitor. So Norway has got amazing monitoring and surveillance of physical activity. It's a little harder in Malawi and Nigeria. And so part of our role is to support some of these countries. And we have the stepwise surveillance package that helps countries look at their physical activity levels. It's a self-reported questionnaire. I think we would all recognize that those questionnaires have some limitations. And so we are working on new ways of assessing physical activity in health surveys. So we're looking at how WHO can be part of setting some standards for wearables for use in population-based surveillance. And we'll probably talk more about that tomorrow, I believe, but this is just an introduction to some of the work that we've been doing, slowly building up this knowledge base, the evidence, so we can go to countries and propose an alternative to them that they'll all be able to implement. So thank you very much for giving me this opportunity to share that work with you. I hope it puts guidelines and some of the work we're doing into perspective and just shows how important this relationship is with academics, with researchers such as yourself who generate that knowledge, but also with policymakers who then use that and use the information we gather on population levels of physical activity to see if their policies are working. Thank you.
And thank you. I guess we will proceed. Ulf Eklund, he has already been on the stage, but I never got the chance to introduce him. Ulf Eklund, he is a professor at the Norwegian School of Sports Sciences. He has a, what is that called? Professor 2, researcher appointment at Norwegian Institute of Public Health. He is deep into physical activity and sedentary time and dose response issues, and he is one of the most cited researchers in the world. Ulf Eklund, ordet er ditt. The floor is yours.
Thanks, Sigmund. No pressure. I think you missed this one. Okay, so what I'm going to try to discuss and take a more deep dive into physical activity and sedentary time, and the subheading of this talk is how much or how little. So Joanna showed this slide, and you could think about this: how much can we actually sit before it's detrimental to our health? And how little physical activity is needed to actually improve our health? And I'm going to discuss first about sitting time, sedentary behaviors, and then move into physical activity, how little physical activity is needed. I'm going to discuss a little bit about total physical activity, intensity-specific physical activity, and how small changes in physical activity may prevent premature mortality. I also think it's important to stress that all data we present are on population level, and they can't be interpreted on an individual level. And that's exactly the same for physical activity guidelines. If the guideline says 150 to 300 minutes of moderate intensity per week, we have very strong evidence that that is beneficial for health. But you can't really say for an individual that it's beneficial to do 150 minutes. And I think it's important to keep that in mind. It's always population levels data we are presenting and we are interpreting. So sitting is killing you. That's something we have seen. That's something headlines in major international newspapers showed up maybe 10, 15 years ago. Why sitting all day may shorten your life. Sitting is the new smoking. That was a classic. Sitting is the new smoking even for runners. And sitting all day at work boosts your risk of death or early death by 16%, etc., etc. And you can see New York Times, Washington Post, CNN, etc. So is it really that harmful to be sitting? Well, sitting became quite interested, or the research community became quite interested in sitting and sedentary behavior around 2010, 2015. I did a quick, a very dirty search on PubMed, where I entered sitting and or sedentary behavior in an abstract search. And you can see the trend, from 1990, absolutely no papers. And then something happened between 2010 and 2015, and an exponential increase in research in sitting and sedentary behaviors. Apparently, there was a peak about somewhere 2018, 2019, and then it seems to be a little bit lower interest. The thing is that when there is a new topic, many people jump on the bandwagon and want to research that topic. And that results in a tremendous amount of new papers. So some of these papers were systematic reviews. Black, no signal. Okay, back again, no. Yeah, here it is. Some of these papers were systematic reviews analyzing sedentary behavior, sedentary time in relation to many of these non-communicable diseases we have discussed. And the conclusion, at least this was one paper published in 2015, the conclusion was that when you adjustment, sedentary time was independently associated with many of these NCD risks or NCDs. Sedentary time was independent. USB-C port is always more reliable than a HDMI.
We'll see.
I'm sorry, I can't sing a song or something like that. Okay. So this is just one example. A systematic review looking at sedentary time and risk for disease incidence and mortality. And they concluded that after adjustment for physical activity, sedentary time is independently associated with a greater risk for CVD, diabetes, cancer, and all-cause mortality. Another systematic review a few years later again concluded that independent of physical activity, total sitting time and TV viewing are associated with greater risk for several chronic diseases. And they all, with a number, a threshold of 6 to 8 hours per day of total sitting time or 3 to 4 hours of TV viewing time increases the risk. So, quite a lot of systematic reviews suggesting that sitting time or sedentary behaviors are really detrimental. However, now we need to go into a very small crash course in epidemiology. Because what this meta-analysis did was that they adjusted the association between sedentary time and mortality or disease outcomes for physical activity in a statistical analysis, for example, in the Cox regression. What this basically means is that you remove the variability in physical activity. You make everybody similar for physical activity. So everybody has the same level of physical activity. And then you look at sedentary behaviors or sedentary time related to your outcome of interest. But in the real world, that's not really what it is. Because if you're not sitting down, if you're not sedentary, you are physically active. If we just ignore standing. So if you don't sit, or if you're not sedentary, you are basically physically active. So in my opinion, I think we should look at those two behaviors in combination. And then there are other statistical approaches to look at this. You can do a joint or combined association analysis, where you examine the association between groups of different levels of physical activity and sitting time against a referent group. And the referent group is usually defined as the least favorable. It could be the most favorable, but the least favorable is those ones who are sitting the most and are least physically active. So that's one approach. The third approach is to do a stratified analysis. And in a stratified analysis, you're looking at the association between sitting time and your outcome, for example, mortality, in different strata of physical activity. And that basically tells you whether physical activity modifies the association between sedentary time, sitting time, and risk for mortality or whatever outcome you're interested in. And I think the two latter approaches are probably more relevant just because of what I previously said. If we are not sitting, if we are not sedentary, and again, if we ignore standing, you are physically active to some extent. It could be physically active with a very low intensity, but you are really moving. And ignore sleep as well, because sleep is something different. But during your awake time. So what we did when Lancet published the series on physical activity in 2016, we were supposed to do a systematic review and meta-analysis on sedentary behaviors or sedentary time and risk for many of these chronic diseases. Then there was this publication in 2015, so we need to rethink. So we did a systematic review, and Jostein was extremely instrumental in that and did quite the hard work of that review. We did a systematic review that we looked for studies who have both sedentary time data and physical activity data. Everything was self-reported, but we came up with about 13 or 14 studies, more than 1 million individuals. And we wanted to look at this combination. So if you combine physical activity and sedentary time differently, how will that relate to mortality? And we looked at all-cause mortality, CVD mortality, and cancer mortality. So that was the aim of this study. And just to summarize it in this slide, with 1 million people, you can create pretty large subgroups. So we had 4 groups for physical activity. This is the most inactive ones. they were active or reported activity of about 5 minutes of moderate intensity activity per day. This is the most active group. They reported about 60 to 70 minutes of physical activity per day of moderate and vigorous intensity. And then you have 2 groups in the middle. So we could cross-classify those with categories of self-reported sitting time, less than 4 hours, 4 to 6 hours, 6 to 8 hours, and more than 8 hours. And the reference group here is in this case, the most favorable one. The ones who were most active and reported the least sitting time. And if you look at those ones who are least active, there is a clear dose-response association between sitting time and all-cause mortality. It's evident, it's quite clear. But if you look at those ones who are physically active, there is hardly any association between sitting time and risk for mortality. We did some sensitivity analysis looking at those ones who reported more than 10 hours of sitting time, and the results were robust. So we concluded from this study that physical activity can actually almost completely eliminate the risk of sitting time with all-cause mortality. And it was quite clear in a subsequent analysis we did for CVD mortality and cancer mortality. So this is self-reported data, and as many previously have alluded to, self-reported data is prone to biases, information bias, etc. So this is a study on device-measured physical activity. It's an individual participant or data analysis, 4 different cohorts, Norway, US, what else? Sweden, Norway, US, and Sweden. I asked Jakob because he was the last author on this paper, where Edward looked at the combinations of, again, the combination of device-measured sedentary time and physical activity. And in this case, if you look at this slide, it's sedentary time here in hours per day, and here's the risk for mortality, and stratified by those ones who are meeting the WHO minimum levels of their guidelines, and those ones who are not meeting the minimum levels. And if you look at the blue line, it's almost flat, suggesting that there is no increased risk for mortality in those ones meeting the guideline. Obviously, you need to be a bit careful out here, because the confidence intervals are extremely wide. But in those ones who did not meet the guidelines, the red line, there is an increased risk, and it starts increasing at about 10 hours and goes up quite steeply. So again, this to some extent alludes to the fact that we could be physically active and offset the detrimental effects of sitting time. So no worries, I'm not going to ask you to stand up. You can sit down, relax, just go for a long walk or a run later on. Okay, so for how long can you sit? Well, it depends. It depends on how active you are, I would say. Sedentary time is associated with a higher risk if you look at it as an independent variable. However, moderate and vigorous physical activity seems to attenuate or even eliminate the increased risk of sedentary time. And I don't think we know the exact amount of physical activity or moderate and vigorous physical activity needed to eliminate this risk. But I think I suppose I would say it's fairly high. It's probably at the upper end of the recommendations. Obviously, it's also probably different between different populations. So that's something we may want to understand even further. Okay, so move on to physical activity. How little is actually needed? I'm going to talk a little bit about total physical activity and then intensity-specific physical activity. This is some data from a fairly large consortium on accelerometer-measured physical activity, where we have included 8 different cohorts, including the Norwegian National Surveillance, the ungKan and 7 other cohorts. And we did a harmonized protocol We asked these cohorts to analyze the data in exactly the same way. We had about 36,000 individuals. Everybody were measured with waist accelerometry. And above all, we looked at the association between total physical activity and risk for mortality. And this is quite clear, this dose-response association. If you're very inactive and you move a little bit, your risk will drop quite dramatically, and at higher activity levels, it basically flattens out. This is expressed in counts per minute, which is very difficult to understand for a lay person. Those ones of us who are working with accelerometry data, we maybe understand it. But 300 counts per minute, it was actually less than the average activity level in the Norwegian population, and very close to the activity levels in the NHANES, which is a representative sample of the US population. So it's not much, it's not extremely amounts of total physical activity needed to obtain this maximal risk reduction of close to 65%, I think. Jakob did a follow-up paper on this, also looking at total physical activity stratified by obesity status. So you have the obese ones stratified into 3 groups of low, medium, and high physical activity, the overweight ones, and the normal weight ones. What I think is quite interesting here is, even in the obese, if you belong to the medium or high tertile, you have a reduced risk of mortality. But if you are in the normal weight group, but in the lowest tertile of physical activity, your risk is actually increased, or even if it's not statistically significant, the trend is that normal weight individuals with low activity levels have an increased risk, compared to the reference group, who is this one. So the conclusion from this one was that high levels of total physical activity is associated with lower risk of all-cause mortality, irrespective of weight status, which I think is a very important public health message. Everybody, regardless of weight status, should be physically active, and the more the better. Belonging to the highest tertile is definitely better. But as I said, this is again total activity expressed as counts per minute. And people don't understand counts per minute, but they probably understand steps. And many people are nowadays measuring their steps with smartwatch or a smartphone or whatever. And we have always thought that 10,000 steps per day is equal to health. And that has been a mantra since the 60s, when the Japanese company came up with the first pedometer and the manpu meter, which apparently means 10,000 steps or something like that. But there was hardly any evidence that 10,000 steps was associated with health. If you look into social media nowadays, YouTube, what's the other one, which I never remember? I'm not on there. TikTok, all the kids are there, and Aline. Sigmund as well. No, 10,000 steps is not enough. Now you should do 50,000 steps, or maybe 100,000 steps in 24 hours, or maybe 2 million steps in 30 days. And it's slightly ridiculous, right? So what does the science says about steps? And Bjørge showed some data from Norway this morning. And this is a very, or quite new meta-analysis on daily steps and health outcomes. And roughly 7,000 steps seems to be the optimal level. If you look at all-cause mortality, there is some sort of a leveling off of between 6,000 and 8,000 steps. And here for cardiovascular disease incidence, again, somewhere around 7,000 steps per day seems to be some sort of an inflection point where the risk starts to level off. So I think steps is an easy measure, maybe be included in the new guidelines, you never know. It's an easy measure, people can measure it, many people do measure steps. However, there is a caveat. And the caveat is that most people measure their steps with a smartwatch. Researchers measure steps on the hip. and there is a difference. This is a paper from 2016, quite old, but still comparing in the same individuals, comparing hip-worn and wrist-worn step measures, and you can see it's almost 90% higher from the wrist compared to the hip. So we have some issues. Even if the correlation is pretty good, the absolute difference is substantial. Okay, a bit about intensities. The current guideline says 150 to 300 minutes of moderate intensity, or 75 to 150 minutes of vigorous intensity, or a combination of both. Basically, a 1-to-2 relationship. So you can do half the amount of vigorous, simply because we define moderate intensity as 3 to 6 METs, and vigorous intensity above 6 METs. Since the guidelines from 2020, which were more or less based on, or at least to 90% based on self-reported data, there has been a tremendous increase in publications using device measured physical activity. And many of these studies comes from the UK Biobank. There is at least one new paper every week using accelerometry data from the UK Biobank with some health outcome. But the question you could ask is really all intensities equal? Would it be, or is it even more important to do vigorous intensity? And how important is light intensity in their overall picture? So this is one paper from the UK Biobank from the Australian group, showing that vigorous intensity lifestyle physical activity is associated with a reduced risk for all-cause mortality. So those ones who had a median vigorous intensity lifestyle activity of about 4 minutes per day, that was associated with 25 to 30% risk for all-cause mortality, compared with those ones who did no vigorous intensity lifestyle activity. This was in a subsample of the biobank accelerometer sample, only in those ones who reported no exercise. So they excluded all those ones who reported exercise. So this is some lifestyle vigorous intensity, maybe running for the bus or walking upstairs or something like that. But again, it alluded to the fact that vigorous intensity might be important, and you don't need to do very much vigorous intensity. Another paper from the same group also looked at vigorous intensity. They looked at all-cause mortality, cardiovascular disease, cancer mortality, and incidence of CVD and cancer. And again, those ones who did no vigorous intensity activity is a reference group for each of the outcomes. And then there is some sort of a dose-response association going from doing a little bit of vigorous intensity to doing quite a lot of vigorous intensity. And the conclusion from this study was that about 15 to 20 minutes of vigorous intensity per week was associated with quite substantial risk reductions for both mortality and disease incidence. They also have also published this paper, and this is just a summary, and I think this is quite interesting because it compares 1 minute of vigorous intensity to the equivalent amount of moderate intensity for different disease outcomes. And we can just look at all-cause mortality. 1 minute of all-cause mortality corresponds to 1 minute of 1 minute of all-cause mortality. 1 minute of vigorous intensity activity corresponds to about 4 minutes of moderate intensity for when all-cause mortality is the outcome. But when CVD mortality is the outcome, 1 minute of vigorous intensity corresponds to about 8 minutes of moderate intensity. So whether this 1-to-2 relationship, which we have based our recommendations on, whether that holds, I don't know. It might be that vigorous intensity is more important. So maybe we should just go and do vigorous intensity. Maybe. This is the question. Should we promote more vigorous intensity on the expense of moderate intensity? You can have your own thoughts. I'm going to expand a little bit on my personal opinion. I think we need replication from the UK Biobank study in many other studies. wrist accelerometry is different to hip accelerometry. I'm not saying one is better than the other. I'm just saying it's different. And you can see from the results here. This is the same individuals doing exactly the same activities using different monitor placements. This is the waist placement or the hip placement. And these are the wrist placements, 3 different wrist placements for running, intermittent running. The wrist picks up much more activity than the hip. And I think we're going to hear much more about this tomorrow during the presentations tomorrow. I suppose there is more noise in the signal from the wrist compared to the hip. And the third thing is that the biobank is a selected cohort. It might depend when you're going to generalize the findings, but it is a selected cohort. They are more highly educated, they are probably more active, etc., etc. So as I alluded to, I think we need replication in other cohorts on the vigorous intensity spectrum. And I'm sure Aidan is going to talk much more about machine learning versus cut points, maybe for vigorous intensity tomorrow, and we can have a discussion about that. Okay, finally, how little is enough? I mean, not all individuals in the general population can participate in vigorous intensity. Not all individuals are able to be active according to recommended levels. So are there any health benefits for those ones who are really not that active? Usually we are trying to establish whether, or previously we have tried to establish whether physical activity, or whether we can remove physical inactivity from a population and make them physically active. What would that be translated into preventable deaths? And we have used a statistical measure called the population attributable fraction. So think about it, if you remove a risk factor from the population, how many deaths could be prevented in that population? For example, if all smokers stopped smoking and become non-smokers, how many lung cancer deaths could we prevent? And this was the question from one of the Lancet papers in the first Lancet series in 2012, where Aimin Lee and co-workers estimated that more than 9% of the global deaths could have been prevented if all those individuals who were categorized as physically inactive, not meeting the recommended levels, just met the recommended levels. However, this measure has some limitations. One of them is that it's obviously much easier to go from, if 22 minutes is the target, it's obviously much easier to go from 20 to 23 minutes to meet the recommended levels, compared to going from 1 minute to 23 minutes, or from 1 minute to 150 minutes per week. That's one thing. The other thing is that this calculation doesn't take into account the dose-response curve between physical activity and risk for mortality. And it's not a linear curve. You have seen it before. You have seen it many times on the slides. So what we wanted to do in this paper which came out earlier this year was trying to understand how many deaths could be averted or potentially averted by small changes in physical activity and reductions in sedentary time. And we used a different measure called the potential impact fraction. And the potential impact fraction takes into account small changes going from 1 to 5 minutes, or going from 2 to 6 minutes, or 3 to 7 minutes, etc. Small changes throughout the dose-response curve for the association between physical activity and risk for mortality. So it takes into account the proportional change in the disease risk, in this case mortality, after a change in the exposure. And we could look at small changes. So we used our consortium with accelerometer data from, in this case, it was studies from Norway, Sweden, and the US. I think we had about 35,000 individuals in that data set. And then we also looked at the UK Biobank data in about 90,000 individuals. So altogether, a data set of 135,000 individuals. These are the results from our consortium. we used individual level data, so we got all the data to NIH, and Morten, who came up with the idea of doing this potential impact fraction, analyzed the data. And if we look at the risk for mortality for a 5-minute increase in moderate and vigorous physical activity, if you go from 1 to 6 minutes, you have a 30% lower risk. But obviously, the more active you become, or the more active individuals are, the less benefit there is. And when you are more active than, let's say, 25 minutes per day in moderate intensity activity, it doesn't matter if you increase your activity by 5 minutes because you don't reduce your risk. I shouldn't say you, I should say the group doesn't reduce their risk. And we could then use this dose response curve and calculate this potential impact fraction. So for those ones who were least active, increasing by 5 minutes from, let's say, 1 to 6 minutes corresponds to 3.5% of all deaths averted. And then, again, if you are active here at about 25 minutes, there is more or less no benefits. And then we can combine all this data into a cumulative potential impact fraction, which I'm going to show you later, or in a minute. We did the same for sedentary time, and in this case, we looked at decreases in sedentary time of 30 minutes, because people are sitting down, and these individuals sat down for about 9 hours per day. So for 30 minutes, can we reduce sedentary time by 30 minutes? What would that correspond to? And it corresponds to about, I mean, there was no, it says increased risk, it should be decreased. So if you don't sit much, there is no decreased risk. But if you go up for about 450 minutes and more, then reducing this by 30 minutes decreases your risk by about 10%. And then we could then also calculate this potential impact fraction. So to look at this, I have some very clever colleagues, much cleverer than I am. So Jakob came up with Jeffrey Rose, and you brought his book today. So Jeffrey Rose was one of those, or is one of those extremely famous epidemiologists. He published a paper in 1990, I don't remember, about a high-risk approach and a population-based approach, and whether we should try to shift the entire population a little bit, or whether we should focus our efforts on the high-risk individuals. And we use this approach and as two hypothetical interventions. Think about looking at the 20% least active ones. If we change their activity, all of them, by 5 minutes per day, that will correspond to 6% of all deaths averted. If we looked at the entire population, except for those ones who are most active, that would correspond to about 10% of the deaths averted. So you could think about it in this consortium, and the biobank data is quite much lower, and I will come back to that if I have time. Do I have time? How much time do I have?
Well,
I'm running over.
kind of, but we are still on time.
Okay, good.
Please continue.
And we did the same for sedentary time, and you can see the figures here. In the high-risk approach, we could avert 3% of the deaths, and we could prevent about 7% of the deaths if we changed or decreased sedentary time by 30 minutes in the two different risk scenarios. So, why are the results so much lower in the biobank? Well, I don't know for sure, but the dose response curve is completely different. So this is, again, moderate and vigorous physical activity, and here is the dose response curve, and it's more or less a linear association. It's not this curve linear dose response curve which we see from the other studies. That may affect it, and the risk reduction is much smaller for a 5-minute increase in moderate and vigorous physical activity. It might be due to the placement of the monitor on the dominant risk, which may produce more noise, obviously, there are different data processing criteria, stuff like that, in the two different data sets. The levels of physical activity was higher in the UK Biobank, and again, the population might be a bit healthier and with fewer deaths. But I think the shape of the curve is quite interesting. It's substantially different from the normal dose-response curve which you saw here. Okay, just to almost finish off. Here is the normal dose-response curve. This is one of the studies we included, the NHANES. It's a population-based American sample. And here you can see this is the dose-response curve which we would expect. But when we analyze the data from the NHANES with a different threshold, and now we're going into technical details, but I think for those of you who are knowing about accelerometry, this might be interesting, because when we use the different threshold for moderate and vigorous intensity activity, a much lower threshold of 760 counts per minute, which was requested by one of our reviewers, so we did it. Then you can see that the association, the dose-response association, is very similar to the UK Biobank Association, with more or less a flat line. And my take on this, or the only interpretation I can come up with, and help me if you can find out something better, I think this is due to noise and misclassification. So if you have a very low threshold for moderate intensity, you will probably classify a lot of light intensity into that category. So there will be noise, and that I shouldn't say it will, it may affect the dose-response curve. But I think it's an interesting observation, at least. Okay, so finally, going back to Jeffrey Rose and his population and high-risk approach. Moving the entire population just a little bit may have substantial benefits for the entire population, but small benefits for the individual. In a high-risk approach, we may have, if we try to move the high risk or intervene in the high risk minority, it may have potential or substantial impact on those individuals, but very little on the population as a whole. And then you can think about which of these approaches you would prefer for different scenarios. Our conclusion from the paper was that small and realistic increases in moderate and vigorous physical activity of 5 minutes prevent 6 to 10% of all deaths, depending on the risk scenario. Personally, I think the population approach much more appealing than the high-risk approach. On the other hand, the high-risk approach actually prevented about 6% of all deaths, and the population approach only 10% of all deaths. So it's an interesting discussion which approach to think about, or which approach to use for intervention, or a combination. So the take-home message is basically that you can be sitting if you are physically active and if you're doing your activity. How little activity is needed? Well, maybe 7,000 to 8,000 steps per day. Total physical activity and intensity-specific activities both contribute to improve your health. And whether we should think about intensity differently, I think it's important to discuss and think about and do more research about the importance of vigorous compared to moderate intensity, keeping in mind that all people can't be active at a vigorous intensity level. And just finally, I know Norwegians are really keen on quizzes. Here is all people who have contributed. All their names have been on the previous slides. So during the coffee break, you can try to find the names for each of the individuals, and there is going to be a prize for those ones who can pinpoint all the names. I leave that up. Thank you.
Tusen takk. Thank you, Ulf. This has been quite a long session so far. Actually, we do have in the program Q&A. How is the feeling? A bit tired? No. You have a question, please?
Thank you for three very interesting presentations. I'd like to ask Joanna, what are the main barriers in a global perspective? What are the main barriers towards following recommendations? Once again. So it's, first of all presentations very, very nice and interesting. And to Joanna, what are the in a global perspective, what are the main barriers to carry out the recommendations? And how would you advise us in Norway to go on?
You've raised a really good point. And I think those barriers vary. So we have looked at the data at the population level, also looking at men and women, and there are stark differences. And in some regions of the world, women are 20% fewer women are active than men. So there are different things happening in different countries, and I think you really do need to look at your national data to understand what those patterns are. And what's become really clear is we need to speak to people to understand what their barriers are. There's been some really interesting work done associated with communication campaigns about physical activity, to use focus groups, to use surveys, to really understand, particularly for groups like women, what is holding them back? Is it that they don't see themselves in some of those campaigns? Is it that time's an issue, the perception that it has to be in a gym with special clothes and it all costs money? So I think understanding individual barriers, community barriers, and how we can get past those is going to be really important. But then at the policy level, it's also understanding those barriers, understanding whether there's something that we can do, for example, to promote active transport, to help people incorporate physical activity into their daily lives, that will help a general population to become more active. If road safety is improved and parents are confident to allow their children to walk or cycle to school independently, you've got kids adding activity to their day. So that there are lots of different ways we need to look at it. But sadly, there isn't one global answer. And I think that's become really clear. We need to understand what the barriers are at a local level. And sometimes those things are really local. It could be at municipal level, to understand what's holding people back in certain cities or certain spaces, and getting to grips with that.
Good. There's one person. Yeah.
No, there's, please use this. There's people listening on the stream as well.
Okay. FOE has 9 targets for NCDs. Wouldn't it be wise to add one, reduce ultra-processed food? Because I think this is just as bad as alcohol and tobacco, since it's exposed to young kids early. So I like to add ultra-processed food as one target more.
Okay, sure, yeah.
So thank you for the suggestion. I'm actually not working with food, but overall looking at the NCDs. So we have in Norway adopted the global targets. So actually your comment is more like we could address it to the WHO to include it in global targets if that's something that they decide to do. So I can't really answer it, but thank you so much for the suggestion.
Thank you. I actually guess that we need a break. And I suggest that we meet back here as planned, but 2 minutes after 3 o'clock. And then we start sharp at 15:05. Okay? A big hand for the presenters. Okay.
Ja, det skal jeg.
Test.
Test. Funka?
So, please take your seats. We are about to begin. Kan FHI och hälsodirektoratet sätta sig ner så vi kan begynna sessionen? Nej. Kan FHI och hälsodirektoratet sätta sig ner nu, tack. Thanks. I am apparently chosen to share the session the last session for this day and the afternoon session. And it's a great pleasure to introduce my colleague, I think former postdoc as well, Knut, the young and talented, the former young and talented, no only talented, Knut Erik Dalene. Please, Knut.
Hello? Is the sound okay? Yes. Yes, thank you. Good afternoon. So today I will talk a little bit about domain-specific physical activity with a particular focus on associations between occupational physical activity and longevity. So because physical activity is any bodily movement produced by skeletal muscles that results in energy expenditure, we are, per definition, physically active unless we are sitting or laying down passively. And there are, of course, several reasons why we are physically active, and we often categorize physical activity into four different domains. Occupational physical activity refers to the physical activity we do as part of our work. Leisure time physical activity is what we choose to do in our free time. Transport physical activity is an activity involved in getting from one place to another. And household physical activity includes the activity we do to maintain everyday life at home. And the same activity can, of course, fall into different domains depending on the context. So the idea that physical activity is beneficial for health is not new, and we can find statements about it from more than 2,000 years ago, if you want. However, modern physical activity epidemiology really only got started in the 1950s with studies like the London Transport Workers Study and the California Longshoremen Study. And these found that workers with physically active job tasks had fewer cases of heart disease and a lower risk of cardiovascular disease mortality. Since then, technological developments have dramatically changed the physical demands of both work and other parts of everyday life. For example, the proportion of these longshoremen engaged in heavy work declined from about 40% in the 1950s to just 5% in 1972. And the proportion of US workers who walked or used public transport to get to work declined by about 70%. Yes. And more recently, the proportion of trips by bicycle in Beijing fell from 63% in 1986 to only 16% in 2010. And household physical activity has also declined significantly. As a result, research has increasingly focused on leisure time physical activity and exercise, finding strong and consistent associations with several health outcomes and longevity. However, many people are still very much physically active in other domains, especially through work. And in countries like Norway, this is especially true for many minority and low-income populations. And despite being physically active for large proportions of each day due to their work, many remain in relatively poor health compared to their higher income counterparts. In the 2010s, occupational physical activity therefore came back into focus. And this was largely driven by what has been called the physical activity paradox. And this is that while leisure time physical activity is consistently associated with better health and longevity, high occupational physical activity, unlike in the 50s, is now associated with increased risk of cardiovascular disease and mortality. And this seems to be particularly evident in men. So what is the empirical evidence behind this so-called paradox? One of the key pieces of evidence comes from a meta-analysis of 17 studies, including more than 190,000 participants, published in 2018. And in that study, among men, high occupational physical activity was associated with an 18% higher risk of all-cause mortality, supporting the idea that high occupational physical activity may actually be harmful, at least in men. But this also raises important questions about interpretation. Does this association reflect a causal effect, or does it reflect something else? One explanation relates to the nature of the physical activity itself. While leisure time physical activity typically involves varied, voluntary, and sufficiently intense activity with adequate recovery in between episodes, occupational physical activity often involves prolonged repetitive tasks, sometimes with heavy lifting, awkward postures, and limited recovery. And it's also typically performed with low control and over long durations. And these characteristics may lead to sustained physiological strain, including elevated heart rate and blood pressure, and over time contribute to increased cardiovascular risk. So, plausible physiological mechanism has been suggested, but at the same time, it's also possible that the associations observed do not actually reflect causal effects. We know that people today with high occupational physical activity, they differ systematically from those with low occupational physical activity. They differ in education level, income, health behaviors, and many other things. So what we observe may actually reflect a complex network of socioeconomic and behavioral factors rather than the effect of occupational physical activity itself. And the key question is therefore, do highly physically active workers die earlier because of their occupational physical activity, despite it? Or maybe occupational physical activity has nothing to do with it at all. Ultimately, this is a counterfactual question that is very difficult to answer with great certainty. We cannot know what would happen if we assigned the same individuals to different levels of occupational physical activity over an extended period of time. We cannot randomly assign people to do different types of jobs over decades, but we can try to approximate it using observational data and try to estimate effects of occupational physical activity, holding other important factors as equal as possible. And this is what we at least tried to get closer to doing a few years ago, using harmonized data from Norwegian health examination surveys in more than 430,000 men and women. And I should add that this was done as a collaboration between the Public Health Institute and NIH at the time. And these data included detailed information on socioeconomic factors, prevalent diseases, and health behaviors. And this allowed us to adjust for important confounding factors when estimating how occupational physical activity is associated with all-cause mortality, CVD mortality, and cancer mortality. So in this study, we used flexible parametric survival models to estimate survival time differences across occupational physical activity levels. We analyzed men and women separately, and we applied increasingly extensive adjustments across 3 models, allowing us to see how the estimates changed as we adjusted for more potential confounding factors, getting us closer to this all else equal scenario. And we also performed several sensitivity analyses to see how robust the estimates were. The median age of the participants was 41 years at baseline, and we followed them for a median of 28 years. And during this very long follow-up, a little more than 74,000 participants died, about 20,000 due to cardiovascular disease, and about 30,000 due to cancers. And now to the results. This figure shows estimates for men with minimal adjustment. It's only adjusted for age and birth year. And here we see that higher occupational physical activity is associated with shorter survival. In other words, men in more physically demanding jobs appear to live shorter lives, both due to cardiovascular diseases and cancer. However, when we added adjustment for education, income, ethnicity, prevalent cardiometabolic disease, and smoking, estimates were completely reversed, indicating that occupational physical activity increased longevity by almost 2 years when comparing the highest and lowest levels. And that higher occupational physical activity was associated with lower CVD and cancer mortality risk. When we further adjusted for BMI and leisure time physical activity, these estimates were slightly attenuated but showed the same pattern. And although slight attenuations and accentuations were observed in the sensitivity analysis, the overall pattern was not materially different. In women, we did not see the same pattern as in men, neither in the minimally adjusted model, in model B, or model C. The only estimate with a confidence interval not including unity was found for the walking and lifting category when cardiovascular disease mortality was modeled as the outcome, but this finding was not robust in the sensitivity analysis. So to summarize, we found no evidence that occupational physical activity per se leads to shorter survival. And I would also like to mention that two newer independent participant data meta-analysis that includes our data from this study, they did also not find any association between occupational physical activity, CVD, or all-cause mortality when they fully adjusted their models. So where does this leave us? Well, this still remains a counterfactual question that is fundamentally difficult to answer. And to move forward, I think we need better data, more accurate measurements of occupational physical activity, ideally combining self-reports and devices. I think we also need to consider additional sources of confounding, and we need repeated measurements over time combined with analytical methods that can handle time-varying confounding. When we consider that occupational physical activity is something that we can be exposed to for 40 to 50 years, this is naturally very important. And finally, in the short term at least, I think, my personal opinion, that other outcomes beyond mortality and non-communicable diseases might be more relevant to look at least in the short term, when considering whether or not to add specific recommendations for occupational physical activity in future guidelines. So overall, improving our understanding of the effect of occupational physical activity, what effect it has on NCD risk and longevity, will require both better data and better study designs. Thank you. That was many words in 15 minutes.
Thank you, Knut Erik. I think we should save questions for later, and we'll summarize this session up with questions and answers. So it's a great pleasure to introduce the next speaker, all the way from Denmark. He told me that he has a world record on Strava, climbing one of the highest mountains in Denmark with an elevation gain of 0.6 percentage. And I think the total distance was 60 meters or something like that.
Yeah.
So, Jakob Tarp, the floor is yours.
Thank you. Yes, it's true. I am the local legend at Ålum in Denmark. Thank you. Okay. So, we have today been hearing a lot about stuff that we have already been doing. Let's start talking about what we are doing now. Let's show some new data. And I will be presenting the obesity project, which has, I think, a very creative acronym. It stands for Obesity, Biological, Sociocultural, and Environmental Risk Trajectories. OBCT, very creative. I think that's very nice. And this is a EU-funded consortium, funded by a little more than 10 million euro, involving 12 European universities, a very large group, and we are represented here at NIH by me and Ulf Ekelund. And the goal of obesity is to find ways of preventing obesity. And the backdrop of that is that we have common Overweight and obesity is common in all European countries, and there are consistent socioeconomic inequalities, which is unjust, and we need to do more for prevention. No country in the world has ever successfully prevented development of obesity or weight gain in their population. And you can see the consistent socioeconomic inequalities here. This is for all of the EU member countries, where those with the lowest level of education have a higher prevalence of obesity, a much higher prevalence of obesity compared to those with a higher level of education. So OECD proposes that to effectively prevent obesity, we need to consider the complex and dynamic interplay between biology, socioculture, and environment, and socioeconomic status across the life course. Very new and very comprehensive approach. And obviously all of these many people will do lots of work, but it's all centered on three main themes that relate to knowledge, maps, and tools. And one example of knowledge is this micro-simulation model that our colleagues at University College London is developing, where they will take all of the data we have on what are the causes of obesity, biology, sociocultural, ethnicity, peers, family, how you eat, your environment, and your socioeconomic position, and life course trajectories. Take all of that and put it into a micro-simulation model, so we can really do different simulations of what are the levers, what happens when we intervene at this specific target, and how will that affect, or how could that affect obesity in the population. We will, our colleagues in Amsterdam will develop maps of all of Europe, showing where are the obesogenic environments, which environments have a high level of bikeability, where are the unhealthy food environments, where are the green spaces, drivability, walkability, and where are the built environments that facilitate development of obesity. They will make maps of all of Europe so we can get a comprehensive understanding of the European picture. And finally, we will develop tools, because unlike what many people may think, we don't have a good understanding about how much physical activity you need to do to prevent obesity or weight gain. The data is simply not good enough, and specifically when taking different age groups or socioeconomic positions into account. So we will provide that evidence that can be used by policymakers. And specifically, our task here at NIH is to focus on physical activity and sedentary behavior recommendations. And we are producing systematic reviews and new analysis on moderate to vigorous physical activity, sedentary time, and daily steps. And today I will just show you a glimpse of what we have been doing, focusing on sedentary time and daily steps. So we did a systematic review on the association between sedentary time and weight gain. As I said, the data that's out there is simply not good enough. There are many reviews, but they are not good enough. We did a very comprehensive review to answer this question. And we wanted to know, what is the relationship? What is the quantitative relationship? And can we actually set a specific recommendation, a target, a maximum number you shouldn't reach? And we looked at adults, and we looked at any types of sedentary behavior, so that includes total sitting, leisure sitting, and TV viewing. So in total, and also specifics. And the data is from prospective cohorts. So these two forest plots show the association between sedentary time and change in BMI per year. So it's yearly change in BMI. And we present our data in two different ways. So we present data for sort of your baseline sedentary time in relation to change in BMI, and then separately for the change in sedentary time over time. So it's a baseline and a change in sedentary time over time. And what you can see here is, first of all, that we weren't able to include a lot of studies in these meta-analyses despite our very comprehensive approach. You can see that the data is mostly from TV viewing, and you can see that the follow-up is sort of 3 to 9 years. And actually the results are fairly homogeneous, so it's fairly similar across the cohorts. Unfortunately, the results also aren't very strong. The association for baseline sedentary time with change in BMI is non-significant, and the effect size is 0.01 kilogram BMI unit per year, so it's a very small effect size. We see the same effect size when we look at the change in sedentary time over time, but now it's significant. And as I said, the effect sizes are fairly weak. But if we look at sort of the cohort average change in BMI, that's only 0.09 BMI units per year. So a 1 hour difference in sedentary time actually explains about 11% of the cohort-specific weight gain, which is, if you look at it in that way, maybe not an irrelevant contribution. I should say that this figure was for BMI only. We also did analysis for weight gain or waist circumference gains, and the results are sort of similar. But when we combine them, use standardized anthropometrics as the outcome, we can combine more data into the same model. We more or less get the same picture, but we had a little more opportunity to look into the effects of, or the associations for specific behaviors. But again, as you can see, it's really mostly centered around TV viewing, and we don't have a lot of evidence for other behaviors specifically. So that's something that needs to be generated. Can we establish a quantitative recommendation? This is the dose-response relationship we can generate from this data. We can include 5 studies, a lot of participants and a lot of cases. So a good amount of information feeding into that model, sadly coming from a limited amount of studies. We can see the dose-response relationship is linear, using 1.5 hours of leisure sitting time per day as the reference. It's linear until around 4 or 5 hours per day, and then it sort of flattens out. And can we set a recommendation based on that data? I think we actually can't, because imagine a recommendation to sit for less than 3-4 hours during your leisure per day. I don't think that's a lot of sitting during your leisure, actually. And the threshold that we could potentially talk about is around here, but the relationship is completely flat at that level. So from this, I don't really think we can set a meaningful target. So coming to steps, and we've been hearing a bit about that earlier today, and Ulf showed some of the evidence leading into maybe a target of around 7,000 daily steps is a useful new target. And that data is from a systematic review looking at many important outcomes, but not really about weight gain or prevention of obesity. And the Australians are actually the first to implement this specific target in their physical activity recommendations, which were released about a month ago. So quite interesting and perhaps a benchline for future national recommendations. We looked at the dose-response relationship between daily steps and body composition in sort of middle to older age men and women from the UK, using the UK Biobank cohort. And that data is based on wrist-worn accelerometry, which makes this a messy signal, but thanks to the work of Aidan and his team, we could apply an algorithm that gave us a robust measure of daily steps. And we coupled that with high-quality measurements of body composition based on DEXA and MRI imaging, so really high-quality data. So the first question is about the dose-response relationship, and the second question is whether the relationship varies by socioeconomic status, dietary quality, or perhaps even genetic profile. These are the dose-response curves showing the 5-year difference in the change in fat mass in these middle-aged men and women from the UK. And we used the 10th percentile as the reference, which was about 6,000 daily steps. And if you remember the data from Bjarke, you can see that that is a lot higher than the data he showed, just illustrating the importance of the placement of the monitor. The data is split by women and men because we can see there are distinct dose-response patterns. This line here is total fat mass, and these lines here are region-specific fat mass. And what you can see is in women, there are linear dose-response relationships, whereas in men, there seems to be an inflection point around 11,000 daily steps, which could potentially be used to inform steps-based target for prevention of weight gain. Are there differences by socioeconomic status, age, and dietary quality? Not really. You can see that sort of similar across age. Maybe association is less strong in the oldest. Perhaps that's not too bad, because weight means something else when you get older. Certainly no difference in patterns across socioeconomic status, which is good. Diet quality, consistent. Your polygenic risk score, so your genetic risk for having a higher BMI, not really a strong effect modification here, but when we look at the baseline BMI status, we can see that the magnitude of the association is stronger in those who were living with obesity at the beginning of the study, which can maybe lead into some nice messages. So you will get more bang for each step if you already have a high weight. So, in conclusion, more sedentary time is associated with weight gain and risk of obesity, but I don't think we can set a quantitative threshold. It looks to be particularly important how sedentary time changes over time. Maybe not what you're doing now, but how it changes over time is important. And maybe 11,000 daily steps could be a target for prevention of weight gain. And perhaps daily steps are more important for body composition in women than in men. Thank you.
Thank you very much, Jakob. Now I know Aline is a bit nervous how you're going to introduce her.
I heard Knut, he was young and talented. I'm not sure where you want to go.
The party queen of the department. Aline is our former vice chancellor. Not sure that's correct. Now back as a professor at our department. And the presentation of your talk is Exercise is Medicine, time to wake up. So if you're falling asleep, it's time to wake up.
It's time to wake up for sure. Thank you, Ulf. And thank you for this opportunity. So as Ulf said, I work here at the NIH, but I'm also the National Director of Exercise is Medicine Norway. So this talk I will talk about exercise as medicine, what we do in the organization, and also how this connects directly to our new research center, ungPAP, and Objective 3, which is intervention studies, and which Sigmund called Exercise is Medicine. We all know, and we have heard many times throughout the day, that participating in regular physical activity and exercise is one of the most effective interventions we have for preventing and managing chronic diseases. The evidence is strong, it's consistent, and is well established. And yet, physical activity and exercise is still not systematically implemented in healthcare. So the key question is not, does physical activity work? The key question is, why are we not using it? The organization Exercise is Medicine is a global initiative. It is led by the American College of Sports Medicine. It is now present in more than 30 countries around the world, and it aims to integrate physical activity into routine clinical care. Importantly, it is not just about promoting physical activity and exercise, it's about embedding it into systems, into workflows, and into decision-making in the healthcare. In Norway, Exercise is Medicine was established in 2011. We are a small, non-profit organization working at the interface between research, clinical practice, and policy. Collaboration is very important, and on the board in Exercise is Medicine Norway, we have medical doctors, we have physiotherapists, and we have exercise physiologists. Our aim is to make physical activity and exercise part of standard care, and our main role has been to translate knowledge into practice and to identify where the barriers are. This slide illustrates the scale of the challenge. We are seeing an increasing burden of chronic disease and rising healthcare costs. In Norway, healthcare expenditure has reached more than 450 billion crowns in 2022. At the same time, healthcare utilization is very high. We have around 174 million consultations annually, including nearly 18 million GP consultations. Despite this, physical activity remains underused as part of the treatment. So the question is not whether we need effective interventions, but how we can better use the ones we already have. Our work in Exercise is Medicine has mainly focused on implementation. We have delivered courses for clinicians, reaching more than 800 participants. We have also contributed to national training programs and are at the present developing practical tools for clinical use. What we have seen through our work is that one of the bottlenecks in our work is education. Physical activity is only minimally integrated into the medical education in Norway. For example, in Oslo, medical students, they receive 45 minutes of teaching on physical activity over their 6 years of training. And the topic is not even part of their exams. In other programs, such as in Bergen, there is currently no formal teaching in physical activity at all. So we are essentially expecting clinicians to implement something they have barely been trained in. And that is a real challenge and a key area where we need to act. To show you some of the work that we have done in Exercise is Medicine, I want to present this study. It's a study where we used a digital activity metric, PI, physical activity intelligence in general practice. The idea here was to use an objective measures of physical activity as part of clinical follow-up, similar to biomarkers. The PI score is developed by NCNU. It's based on your heart rate, and you get your PI score on an app on your phone. Patients with type 2 diabetes, they were included in the study. They were given a Garmin watch from their GP and instructions on how the PI score worked. The GP was also trained in motivational interview. And the idea behind it was that it should be motivational for the patient, and it should also be easier for the GP, as they now had an objective metric they could use in consultations. And what we found was quite interesting. For some patients, it worked very well. It provided motivation, and it made physical activity more attainable. But it did not work for everyone. And the main barriers that were reported both by the patients and by the doctors were reported to be technology, structure, and support systems. In this study, the main barriers were not knowledge, it wasn't motivation, but it was by the doctors and the patients reported to be lack of time in consultations. It was lack of system for follow-up and limited interdisciplinary collaboration. In other words, it's not primarily a knowledge problem, but an implementation problem. And this is also where research becomes critical. I made this figure to illustrate the core challenge that we are addressing. On the left side, we have strong evidence. We know that physical activity and exercise is highly effective. But in the middle, we see a clear implementation gap. Physical activity is still not systematically implemented in the healthcare. This is due to lack of training, limited structures, and fragmented follow-up. On the right hand, we see 7 key actions. These 7 key action points are suggested by us in Exercises Medicine to the Directorate of Health when they asked us how physical activity could be easier implemented in the healthcare system in Norway and how we could use physical activity more as a preventive tool. And to address this, we proposed these 7 key actions. These include better measurement through digital tools, strengthening education of healthcare, as I've already talked about, healthcare professionals, and also developing new collaboration models. For the new collaboration models, we think there is a strong need for interdisciplinary teams, where physical activity is not an add-on, but an integrated part of care. This also means making physical activity professionals and exercise physiologists who have specific expertise in using physical activity and exercise as both prevention and treatment. And today, this competence is underused in the healthcare systems. We also highlight the importance of lifestyle intervention, mental health integration, and targeted efforts in elderly care. And finally, we also need incentives to promote physical activities. These are incentives on different levels, but it includes incentives for healthcare professionals to actually prioritize physical activity and exercise in treatment. But we also propose workplace incentives, for example, tax benefits for companies that facilitate physical activity for their employees. Our 7 suggested key actions raises important questions. How do these solutions actually work in practice? And this is where our new research center comes in. We are now establishing the new research center, ungPAP, with a nice acronym. And one of the focuses is how to use physical activity and exercise in prevention and treatment, with strong emphasis on intervention studies in real-world settings. And the goal is to understand how physical activity and exercise can be implemented in healthcare systems across populations and at scale. So, with a key focus on the implementation, some of the key questions then become: how do we deliver interventions in practice? For whom do they work best? And how can they be scaled within healthcare systems? And these are some of the questions we aim to address in ungPAP. In many ways, exercise is medicine, and ungPAP represent 2 sides of the same coin. One is focused on implementation and system change, and the other is focused on generating the evidence we need to support the change. And together, we aim to bridge the gap between what we know and what we do. So, to summarize it all, we do not lack evidence that physical activity works, but we lack the system that enables us to use it. To address this, it will require interdisciplinary collaboration, system-level thinking, and strong implementation research. And these are our social medias, and please follow us if you want to. Thank you.
Okay, last but not the least, it's time to introduce our head of the department, Hege Klem, and Julie Stang, who's going to talk about respiratory health and lung function and whatever. I don't know exactly what you're going to talk about, but we'll see. The floor is yours.
Thank you. Yes, this is the last session, and this is going to be slightly different, I guess. So let's everybody take a deep breath in and release.
Close your eyes.
Not yet. Keep your eyes open. So we are going to talk about respiratory health because we are a part of a bigger research group on respiratory illness at the NIH. And we are doing a lot of different projects, and we're going to give you a potpourri of what we are doing and what we want to do. But the connection is that respiratory health is related to physical activity. And if you can't breathe, you can't be active. So you need to breathe. So, and respiratory diseases represent a major global health burden. It's one of the 3 major non-communicable diseases in the world. And it's connected to the United Nations Sustainable Developmental Goal, number 3, that we need to reduce the non-communicable diseases. And it's also connected to number 11 and 13, which address air quality and environmental development. Environmental determinants, like how a city is built, how swimming arenas are built, and how we are designing our cities. And the global burden of asthma is really, really high. Around 300 million people in the world got asthma. And it's yet very underdiagnosed, and it's also under-researched. But we are interested in breathing problem related to exercise. And we are also interested when breathing problems hamper participation in physical activity. And we're going to show you some clinical examples of that. So the important thing is that we don't only want to look at asthma. We want to look at the total respiratory system, from upper airway and lower airways. And there have been done some studies, and this is one study done in England on respiratory illness in athletes. And the results from this study on the respiratory illness in athletes show that 22% had asthma of those, 22% had dysfunctional breathing, and 34% had laryngeal dysfunction. So that shows us that if you only consider asthma, which is important, but if you only look at asthma, you are at risk of neglecting 56% of other treatable causes. So we need to look at all these conditions, which is called ALO, exercise-induced laryngeal obstruction, BPD, breathing pattern dysfunction, and of course asthma, and ABE, which stands for exercise-induced bronchoconstriction. And I'm going to tell you a little bit more about ALO. Because between upper airway and lower airway, we have a body part called the larynx, which is the valve, and it protects the lower respiratory, protects the lungs. But if you have inducible laryngeal obstruction, this is the larynx. This is the air pipe, vocal cords here, and this in front here is the tongue, so you can't see that. But this is a larynx, normal larynx standing wide open. But if you have altered ventilation, which can be triggered by exercise or other respiratory diseases. Of course, in most of the cases, it is normal, despite these triggers. But in some cases, you can induce laryngeal obstruction, as you see here. And if exercise is a trigger, then it's called ALO, exercise-induced laryngeal obstruction. And I guess everybody actually has heard ALO, and I hope the sound is working here. It's not. Can we fix that? Or maybe it's... no? Okay. Okay. Has anyone heard that sound before? Yes. And people are thinking, oh, that's my asthma. It's so bad. It's not asthma. This is ALO. This is what ALO sounds like. And this is also how a normal larynx during exercise looks like. Standing wide open, allowing good airflow in and out of the larynx. And this larynx can cause problem if it's closing. I'm going to show you one example of this. This is a patient of mine from 10 years back. He was 7 years old. He was unable to play with friends. He was starting school. He couldn't play football with his friends or play with his mates in spare time. The parents are really, really afraid. He was on loads of asthma medication, and he couldn't run because the asthma was so bad. But then we thought, oh, maybe it could be something else. At least we need to try to look for that. And we did this test where we looked at his larynx, and you can see that this was his problem. And you can barely see him that, and he's only walking because he couldn't. He said, I can't do anymore, he said. And it's totally obstructing his larynx. And everybody thought that he had asthma, and that's the reason. So we need to be aware of this patient. And he needed surgery, and he came back, and now he could play with his friends and perform sport. And it's not perfect, but you see that now it's it's opening, so he can actually breathe, and he could run, and he could play football, and he could be active, which is really important. So what we are afraid of is that breathing problems during physical activity leads to inactivity, and then other health problems in the end. So we need to see what we can do to prevent breathing problems to hamper physical activity. So that's one perspective. But then we have the other perspective, which is the athletes. And we have a lot of research going on athletes because 50% of acute illness consultation at sports events actually involves the respiratory system. So this is a population at risk, and we can learn a lot from this population. That's why it's interesting. So they have high-intensity training, are pushing the respiratory system, and they are exposed for environmental pollution and temperature and chemicals over time. And they have a high prevalence of asthma, exercise-induced bronchoconstriction, exercise-induced laryngeal obstruction, and breathing pattern dysfunction. All these three are kind of equal prevalent. So just to show you a little bit of what asthma or lower airway disease is, what is the problem here? And we don't know all the answers here, actually. We know a lot about asthma, but still we don't know the answer of everything. And that's why it's called lower airway disease, because it can be different phenotypes. Because when you have asthma, you have this condition here where there's inflammation, it's swollen lining, and excess mucus, and also tightening of the muscles. So it's hard to breathe. But if you have exercise-induced bronchoconstriction, you have transient airway narrowing triggered by exercise, with or without inflammation. And the symptoms is quite similar. That makes it really, really difficult. And we don't know actually how to be sure to differentiate it. So there's lots of knowledge gaps here. Because asthma, traditional asthma triggers is like polluted air, pollen, animals, cold, and exercise. And on the other hand, sports asthma, it can also be developed by a lot of training in cold air, polluted air, heat, or during swimming pool. But it takes a little time, so it can be considered as an occupational disease. And of course, infections is also increasing the risk. So, among 20% of all athletes have lower airway dysfunction, asthma and or exercise-induced bronchoconstriction. And we see that it's more prevalent in the aqua athletes and in winter. So there's something happening here. And this risk, this population risk, we can study that, and maybe we also can help the general population to study this. And then we have some studies going on, which Julia will tell you a little bit more about now. And we will wrap up in the end with what we want to do for the general population after.
Yes, thank you. We have a project called the SHAPE study, where we're trying to use this new type of technology to improve the air quality in swimming pools, along with a very interdisciplinary research group and collaborators. And why is that we see, as Hege said, that the incidence of asthma or other airway diseases is really increased in swimmers. And studies show that the risk of asthma increases with time spent in swimming pool in children. And at the elite athlete level, we see a really high prevalence of EIB. And this has been linked to the exposure and the inhalation of the disinfection byproducts in the swimming pool, such as chlorine. We have designed this study where we're trying to change the ventilation systems in the swimming pool. The ventilation is originally designed to sort of take care of the buildings and not the people that are using the pool. So as you can see, all the fresh air that's coming into the pool is just going up towards the ceiling, and nothing is occurring in the breathing zone. So all of the chlorine byproducts that are produced in the water, they are just staying here in the breathing zone. So it's not actually very heavy technology. It's very easy. Doesn't have to be that difficult all the time, but we are trying to. It's really, really complicated. We're trying to change the airflow in the pool so that we can remove the air or sort of replace the air in the breathing zone. And we are testing if this can improve the respiratory health of both recreational and elite swimmers. So in this study, we finished the data collection in January, and we have a PhD student who's really working hard on these data right now, and we're really excited to see the results. Another thing about the swimmers is that their lungs are really big, so they sort of have also maybe a positive side of doing all of this swimming practice, but there's no longitudinal studies on this, so we do not know if this is, if they're born that way, if the people with sort of large lungs are the one who will continue and succeed in swimming, or if
this is developed through their sort of special way of breathing underwater, and you see how they're inhaling, filling up their lungs. So we are doing this prospective longitudinal study. We are including swimmers at 11 years of age, and we're following them up until they're 18. So every year they come in to Norwegian School of Sports Sciences. We measure their lungs and also their lung volumes. And then we are measuring their lung function before and after swimming. We're measuring their body composition. We're doing a lot of questionnaires. And our goal is to have 150 swimmers at 18 years. So currently we have included 300 11-year-olds, but they are quitting, as you probably can relate to. So right now we have 80 that are 14, and we have only 10 that are 18. So we're going to be doing this for a while more. But what we see from the data that we have is that at 15, when we're comparing them to another cohort that we are in from a study from this school, is that at baseline they are comparable or have the same lung function as handball football players at the same age. But now we see at 15 years that the swimmers are starting to improve or increase, grow more than what's expected. And also we see a really high prevalence of EIB. A last study that we are doing here is maybe on the other side of Ulf's dose response curves. These are not really sort of elite athletes. This is normal people, or not really normal maybe, but they are regular people that are practicing or doing extreme sort of endurance competitions. And these are becoming more and more popular worldwide. There are 250 slots in this Norseman Ironman triathlon competition. And I think it's about 6,000 every year that wants to participate from all around the world. And what they are really wanting to do is to jump in this ice-cold fjord at 5 o'clock in the morning and then swim 3.8 kilometers, and then bike 180 kilometers above 2 sort of mountain passes before they just run a marathon up a mountain. That's about 1,800 meters. Yes, thanks. And then they reach the finish. This is always not that this kind of weather, but the best males spend almost 10 hours, females about 11 hours, but most people spend more time than that. And this study is led by Professor Trine Stensrud, which you see here in her natural habitat. And we test all these athletes the day before the competition, and when they reach the top at the finish line here, and as well as the day after. We don't only measure the effects on the pulmonary system or the lung function, but also the heart, cardiovascular system. We do blood samples. And just very short, we see that a lot of them have a quite substantial decrease in their lung function. And even the day after, they are quite reduced. And we also see that they are really high on the biomarkers suggesting heart failure. So if they were to go to an emergency, what's it called? Department, they would be diagnosed as heart failure. We have some that we have gotten to come back here to NIH 14 days after, and then they seemed quite normal again. Yes.
So we are looking at different aspects of this respiratory illness and physical activity. It's a wide spectrum. And we are, of course, looking from like physical activity as a risk factor for respiratory illness, and also physical activity as beneficial for respiratory health. But the big question is, how does actually exposure lead to disease? And one thing that has crossed our mind is that we are in a time period where the climate change is happening. It's a lot of pollution, it's a lot of heat, dry weather, it's colder somewhere. And this will probably affect our respiratory health. But we don't know how, and we don't know when. And in Africa, it's not done so much research, but they have seen that they can adapt training hours and location to breathe better. Because, like Kipoche said, if you run in a polluted city, you can decrease your performance. That's their experience. And they have sensors installed in stadiums and training centers to see how much pollution there is and try to prevent breathing and training and exercise in those environments. But we don't know the dosage and we don't know the risks, actually. So what we actually want to do, this is a huge project, and we are just starting to look at how we can design this. But we really want to look at this environment, as Julie talked about, also the swimming pools, the climate change, the pollution, and look at also sport-specific exposure, and also take into consideration not only asthma, but also ALO and breathing pattern dysfunction. And then see what time and dose response is needed to have a disease. And I'm not going to go into detail here, but this is 5 work packages that we have designed, which looks at susceptibility and risk, exposure, disease, intervention and prevention, and then in the end here, the impact. And we are thinking that this work package 5 is best fit within ungPAP center. Because here we would like to translate the knowledge from the athletes to the general population. And we will use sport as a model for respiratory health, risk and dose response, because then we can study those at risk and see how we can translate this into the general population. And then we also want to change and implement the guidelines and screening strategy to see how can we prevent disease from happening, and so that people can be physical activity without any risk for hampering respiratory health. And we also want to, with this knowledge, to support adaptation to future climate change, so that we don't risk our respiratory health. So this was the potpourri of respiratory health and general population and athletes from us.
Thank you very much. Thank you very much, Hege and Julie. I think we have time, or I think in the program it says question and answers, and I suppose all the presenters, Knut Erik, Jakob, Elaine, Hege, Julie, are prepared to answer any questions you may have from the audience. Please feel free. And it's perfectly okay to ask your questions in Norwegian, if you prefer.
Just give me a second.
Ladies first.
Sorry. Thank you very much. I'm really interested actually in that work you're doing about the climate and air pollution. Can you just tell us when you think you might have some of that and the application of that to the general population ready?
Oh, thank you. Thank you very much for your interest. That's encouraging. Hopefully we will be able to write an application this year. That's our goal. Yeah, and we need to find a call that fits. So if you have any suggestions on that, so.
Only our new sources of money.
Yeah.
I really hope you do, because I think I get asked very often about the risks of people being active in climate polluted environments. So,
Yeah. Thank you.
For Knut Eirik. So with your findings regarding occupational physical activity and the later also the findings for the following meta-analysis, is the physical activity paradox still a thing?
Hello? Yeah. I guess it kind of is, because I mean, even because for leisure time physical activity, there's a clear dose response. It lowers risk quite a lot, right? And what kind of evidence has shown now the last 5 years is that we have ended up with occupational physical activity kind of not being associated at all. And physiologically, that's a little bit strange, maybe. But as I said, I think that we're kind of stuck, because the data we have to study is very limited. So to get any further, we need much more better data than the data that kind of sparked this idea 10-15 years ago, because now there's been many studies with self-reported crude data on occupational exposure, and to get anywhere, we simply need much better data. So if that's an answer.
There are believers and non-believers. Any other questions? Yes, good. Johan.
It's also to Knut Eirik, to grill you a bit. I'm just wondering how switching occupations is typically handled when you look at occupational data.
And that's one of the major limitations of these studies, because what you typically do is you measure occupational physical activity at one time point. And then you follow people, and you don't know what happens from when you measure their occupation, or ask them to self-rate their perceived occupational physical activity. So that's why I said we need data sets with repeated measurements over many years that not only assesses the activity level, but also many other factors.
Lene?
Thank you very much for a very nice session, and also for Knut Eirik. Can you try to explain the difference you see in the genders? And or what is your opinion, your reflection?
First, I would like to add that the study I presented was published in 2021, and I haven't really worked a lot on this field since then. But I mean, the jobs that women do that are physically active, for instance, working in healthcare, might be quite different than occupations that men working with similar activity levels. So you have, for example, night shift work, which you should take into account, which we didn't and many others haven't done, which increases the risk of several other things by itself. And then there's also the possibility that men and women pursue their activity level different. So they might categorize themselves differently at the same activity level, I think. But these are speculations, of course. Yeah.
I think we need to have a question for Jakob as well, and one for Aline. So I'm going to ask Jakob. You showed on your data from the UK Biobank with the steps and fat mass, but I don't think you explained it because you only included about 9,000 individuals in that analysis, and others using biobank data has 90,000 individuals or even more using the accelerometer. Can you just explain to the public why, or to the audience why you only had 9,000 people in your study?
Yes, that was because they needed a follow-up measurement on the imaging assessment. So in the other cohorts, their outcomes are taken from registries. Here they needed to come in on a second occasion. So that's why. Thank you for this excellent question, Ulf.
You should never take him for granted. Aidan, please.
I've got a question for Ellen then. So I was just very curious for the planned new work that you'll have in exercises medicine. Will you conduct some randomized control trials? And I'm quite curious maybe in which disease areas you might do that. And then also, will maybe devices be in as endpoints or as a part of the intervention component itself? So we're very keen to learn in the UK from the work that you're doing here in Norway.
Okay, that's a very good question. Yes, that's what we hope to do in when this new research center started. In exercises medicine, the organization, we have not have kind of that's just something we do kind of besides our job, so it has been hard to do any of those studies. But now that it's a part of our research center, I think that's where we want to go. But into what disease we want to go or what we kind of want to do, we're not quite there yet. So it's a good question, and I don't really have the answer. But thank you. Yeah.
Okay, I think we can conclude and close this session. And thanks to all of you who have been here today. And I hope to see you all back tomorrow at, when do we start, 9? I think we start at 9. Yes. And I think you have some announcements tomorrow.
And also, you're all more than welcome to join us in the cafeteria. There will be some light refreshments, some food and drinks if you would like to keep networking and mingling. So we'll just head up there shortly. Thank you.
Yes,